Hypertension Awareness Series Episode 5B. Why cardiovascular risk matters, not the blood pressure level alone. Good morning. Two people can have the same BP readings, but very different chances of getting a stroke, a heart attack, or kidney failure. This is because the blood pressure level is only one piece of the cardiovascular puzzle. Most heart attacks happen not just because the BP is high, but because of multiple risk factors that act together over time to damage blood vessels and vital organs. That is why current hypertension guidelines no longer ask, what is your BP level? But we also ask, what is your total cardiovascular risk? What is your total cardiovascular risk? So cardiovascular risk means your overall chance of developing serious heart or blood vessel disease within the next 10 years. This include getting strokes, heart attacks, heart failure, kidney failure, sudden death. It reflects how much silent damage is likely to happen if nothing changes. So what determines your cardiovascular risk? The cardiovascular risk depends on the combination of multiple factors. These are biological factors like your age, your gender or sex, your family history of heart disease, of cardiac disease. Metabolic factors like, do you have diabetes? Is your cholesterol high? What is your weight? Are you obese? It also depends on lifestyle factors like smoking, physical inactivity, and the clinical factors like your blood pressure level, existing organ damage, heart, brain, kidney, eyes, etc. This is why BP alone can never tell the whole story. A mildly elevated BP with many risk factors may be more dangerous than just a high BP alone in a young person. So how do doctors estimate cardiovascular risk? We use various risk scores and risk calculators that are easily available and guideline approved. One, from the ESC guidelines, we have the SCORE2 and the SCORE2-OP. From the American ACC/AHA guidelines, we have the ASCVD calculator. They estimate the 10-year cardiovascular risk of disease and guide how early and how aggressively you should act. We also have the WHO-ISH calculator, especially the Afro-E, which is for the African region. It is based on the age, gender, you smoke or not, do you have diabetes or not, what is your systolic BP level, and cholesterol levels. And you are able to estimate the 10-year risk of getting a cardiovascular effect. And this is very practical, especially in our setup with limited resources. It allows for risk-based calculations even in resource-poor setups. Cardiovascular risk changes your decision. Let's look at examples. Look at our 40-year-old male with a BP of 145/85 who is a smoker with diabetes and high cholesterol. He is a high CV risk, more than 30%, and he needs aggressive medications from the word go. Another 40-year-old with the same BP of 145/95, non-diabetic, non-smoker, normal cholesterol. His risk is low. He just needs lifestyle modifications alone. The other example is a patient with any BP but has had stroke, a heart attack, or kidney disease. This is very high risk and requires aggressive management. Same BP, complete different risk. This tells us that we should not just be BP-centric, just looking at the BP. You must evaluate and even ask your doctor for your overall cardiovascular risk. What is your 10-year risk of getting a cardiovascular event? So what should you ask your doctor if you have hypertension? What is my BP stage? Question number 2, what is my 10-year cardiovascular risk? Number 3, do I need lifestyle changes alone or medications too? These questions help you become an active partner in your treatment. And to the healthcare professionals, the doctors, the clinicians, do not be BP-centric. A mildly elevated BP does not mean mild risk. Always calculate the overall cardiovascular risk. Use guideline-recommended risk tools and look for silent organ damage. Treat the whole person, not just the BP level. Risk-based care saves more lives, prevents more complications, and you are able to act early. Let me stress again, don't just be BP-centric. Look at the overall cardiovascular risk. And I'll mention more about the WHO ISH cardiovascular risk estimation. For the African setup, we use the Afro-E. These are simplified charts that you monitor. And you look at simple things. What is the age? The age is very simple. What is the systolic BP level? Is the person a smoker or a non-smoker? Do they have diabetes or not? And if you have a lab available, you check the cholesterol. These are simple charts that you can even pin in a clinic setup. And even the patient themselves is able to check and see where they fall. Low risk, moderate risk, high risk, or very high risk. I'll post those in the page later. Simple risk calculation. We don't just look at the BP alone. Same BP, different risk. That person with 145/85, someone with diabetes, a smoker, will need to start treatment and high cholesterol. Another one with 145/85 who has no diabetes, no smoking, will just need lifestyle alone. Cardiovascular risk, the overall cardiovascular risk is more important than the BP alone. For all who have hypertension, please always ask your doctor, what is my overall cardiovascular risk? And you can even get those risk calculators online and check where we are. To the healthcare providers, once again, let us not be BP-centric. Let us look at the overall cardiovascular risk. This is more important than the BP alone. So stay tuned for our next episode where we will look at white coat hypertension and masked hypertension. Doc, my BP is only high in the doctor's office. Do I need to get worried? As always, Dr. Beatrice Muthui-Mutua, saving lives one heart at a time.